Okay, so this is an extremely high yield question for USMLE for your step 1, GI and cardio. For your step 2, this is all over surgery, IM, and FM. The challenge here will be for me to keep this clip as concise as possible because there's so much to talk about, but I know you don't want to see a 47-minute clip, okay? So I'm going to provide some concise value here, tell you exactly what you need to know because students get this question wrong all the time. So before we get started, allow me to be an asshole like I usually am, tell you to subscribe to my channel. I really appreciate it. Help grow this channel, share with one of your friends prepping for USMLE, help bring awareness to this channel. Hit the like button, hit the bell if you want notifications. Find me on Instagram at Mehlman_medical, MEHLMAN_medical. Link is down below. And find us on Telegram. Recently created a Telegram group and channel. The links are down below. Now let me start the actual question. So we've got a 71-year-old male, 2-day history of painless bleeding per rectum. Long-standing history of type 2 diabetes, mellitus, and hypertension. He has occasional pressure and discomfort in his upper legs that's relieved with rest. And he had CABG, coronary artery bypass grafting, 5 years ago. Blood pressure is remarkable for 150 on 90. Hemoglobin is normal at 14 grams per deciliter. HbA1c elevated at 10.5%. And colonoscopy 1 year ago showed no abnormalities, okay? And auscultation of the chest shows no murmurs. So there's a lot to talk about. So one thing I'll comment on is that he has major risk factors for atherosclerosis, okay? Diabetes, most acceleratory risk factor for atherosclerosis, followed by smoking. And even though they don't mention smoking here, he has the long-standing history of diabetes. And then hypertension is most common risk factor for atherosclerosis. The discomfort and pressure in his upper legs that's relieved with rest, that is intermittent claudication, okay? So pain, pressure, discomfort in the legs starts around the buttocks, can proceed to the calves, of course, but this is intermittent claudication. This is due to atherosclerosis in the aortoiliac vessels. And he has the history of CABG 5 years ago. That's merely telling you atherosclerosis in his coronary arteries. And the colonoscopy 1 year ago is showing you no abnormalities. The implication being this is likely not cancer. It's not to say it's impossible. Obviously, patients could develop cancer within the past year, but for the sake of this vignette, in combination with the massive cardiovascular findings, this is unlikely to be cancer in this case, okay? And the auscultation of the chest showing no murmurs, I will discuss that further in a moment. So to go through these answer choices, I'm actually going to start off with chronic mesenteric ischemia, which is the wrong fucking answer, okay? Now, chronic mesenteric ischemia, this diagnosis is really, really important for USMLE. They're going to give you a patient with a big cardiovascular history who has abdominal pain 1 to 2 hours after eating meals, okay? And this is due to atherosclerosis of the SMA or IMA. So it can sound like a duodenal ulcer at first. You say like, well, isn't a duodenal ulcer like H. pylori or gastronoma? Like, wouldn't that be like pain 1 to 2 hours after meals? Yes, however, rather than giving you a 29-year-old dude from Indonesia, the vignette's going to be a big paragraph about cardiovascular risk factors, atherosclerosis, and then they'll tell you the guy or gal has pain 1 to 2 hours after meals, okay? That's chronic mesenteric ischemia. It's not the answer in this case, but I start off mentioning this because now I'm going to mention acute mesenteric ischemia, also the wrong fucking answer. But there's 3 ways this presents on the USMLE, okay? The first way is going to be acute on chronic, where you're going to get a rupture of an atherosclerotic plaque in someone with chronic mesenteric ischemia, and it now presents as pain out of proportion to the physical exam. So for example, they can tell you a guy has long-standing diabetes, hypertension, CABG, intermittent claudication. He has a 2-year history of pain in the abdomen 1 to 2 hours after eating meals. So that's his chronic mesenteric ischemia. And now he or she has a 2-day history, okay? It can be hours, but I've also seen I've seen a 2-day history of severe abdo pain, okay? So they're talking about acute on chronic, where you've had a plaque that's ruptured, and you now have occlusion of the SMA or IMA. That's acute mesenteric ischemia, pain out of proportion to the physical exam. So the other 2 ways acute mesenteric ischemia presents is actually most commonly, it's going to be patients who have atrial fibrillation, okay? They could mention hyperthyroidism as an example, which can imply arrhythmia such as atrial fibrillation, or they can just tell you straight up the patient has history of AFib, meaning left atrial mural thrombus, the clot will launch off to the SMA or IMA, cause pain out of proportion to the physical exam. Okay, that's acute mesenteric ischemia. You're going to do mesenteric angiography to diagnose both of these, acute and chronic, by the way. The other way acute mesenteric ischemia will present is pain out of proportion to the physical exam in someone who was just recently defibrillated or cardioverted, okay? Implying that the patient probably had a mural thrombus, even if they didn't mention AFib, the patient probably had a mural thrombus that launched off to the SMA or IMA. So now we've covered acute mesenteric ischemia, chronic mesenteric ischemia, a lot to talk about, but very important diagnoses, both wrong in this case, okay? Angiodysplasia, wrong fucking answer. This is going to be painless bleeding per rectum in elderly. Third most common cause of painless bleeding after diverticular bleed and colorectal cancer. The reason it's wrong in this case, not to say it's impossible, but the reason it's not the correct answer is not only that this patient has a big cardiovascular history as we've described, but auscultation of the chest shows no murmurs. USMLE, if they give you angiodysplasia, they actually like to tell you the patient has aortic stenosis, okay? Or they'll tell you the patient, they'll say it's an older guy who's arguing with his wife, got chest pain, and he also has bleeding per rectum. That's angiodysplasia. It's called Hayd's syndrome. You don't need to know that eponymous name. I'm just telling you for the sake of it. Heyde. Hayd's syndrome is aortic stenosis plus angiodysplasia. For whatever fucking reason, aortic stenosis can increase the risk of developing angiodysplasia, probably due to pressure effects. Angiodysplasia is tortuosity of the superficial vessels in the bowel. Okay, it can cause painless bleeding per rectum in elderly, but not the answer in this case. Now, choice D, colonic adenocarcinoma, as I already mentioned, not the correct answer because colonoscopy a year ago it showed no abnormalities. Not to say it's impossible, but we have a big cardiovascular history here, which makes ischemic colitis the most likely answer. Okay, this is correct because we have blood in the stool in someone who has a big cardiovascular history. Okay, ischemic colitis is going to be due to ulcers, ischemic ulcers of the watershed areas of the bowel, most often the splenic flexure or the rectosigmoid junction. So we can get bleeding, okay, usually painless bleeding in elderly patients who have big cardiovascular history. That's ischemic colitis, okay? Students confuse this with chronic mesenteric ischemia, which, as we said, is abdo pain 1 to 2 hours after meals in patients with a big cardiovascular history, okay? That's not the vignette we have here. Okay, this is bleeding per rectum from the splenic flexure or rectosigmoid junction, ischemic ulcerations, okay, in patient with big cardiovascular history. Okay, as I said from at the beginning of this clip, the big challenge here is to discuss this concisely because we could literally do a 37-minute oral presentation on this stuff. However, I know you guys don't want to see that. So if you like my stuff, subscribe to my channel, and I appreciate your time.